Hi guys, welcome back. The next topic I'm going to teach you is deep vein thrombosis and pulmonary thromboembolism. And based on my experience of previous 15 years of teaching young budding doctors, I can say that the current topic that I'm teaching you is the second most important topic in pulmonology section after pneumothorax. So that's about the importance of studying this topic in completion. And then I would like you to focus on this image which was given in the recently concluded exams where they had himself labeled this as CTPA, that is CT pulmonary angiography. All you had to identify in this was a couple of blood vessels, and I'm gonna just mark them before you. Posteriorly, you can see the descending aorta, which is adjacent to the vertebral body. Anteriorly, you can see the ascending aorta, and then I'll mark in color blue. This is gonna be the delineation of the pulmonary artery, which you can see very clearly is bifurcating into two. And now you can see a huge filling defect of a clot which is occluding the bifurcation of the pulmonary artery. So the current image at the moment shows a large saddle embolus which is sitting at the bifurcation of the pulmonary artery. This will explain the development of sudden onset respiratory distress that would be developing in this case. This patient might have undergone any major surgery. Post major surgery, because of immobilization part, there would be deep vein thrombosis. The clot could have developed in the soleal veins or maybe in the popliteal or maybe in the femoral vein. As clots tend to develop in the more proximal veins or larger caliber veins, the size of the clot will also be bigger, and therefore a person can end up with possibility of massive pulmonary embolism. During the course of my discussion, I'm going to teach you regarding massive pulmonary embolism, submassive pulmonary embolism, or plain pulmonary embolism. And because you are aware of the fact that anybody who's undergone a major surgery because of immobilization is at risk for development of stasis of blood in the calf veins, and therefore chances of clot formation is there. Therefore, in the second image, they had just asked for what does this image show, and you can see this compression stockings here. These compression stockings are connected. You can see some connections here. This would be connected to a air pump, and the function of this air pump would be that it will fill up air in the stocking, so it will squeeze the legs. It would be akin to walking, like you're aware of the word peripheral heart. I mean, of the soleal muscle is the peripheral heart. When we walk, it constricts these veins and therefore the blood flows towards the heart. But if a person is lying down in the bed for a fairly long duration, after, let me say, stroke, or maybe he had underwent a major surgery, patient could have undergone cancer surgery, then post surgery, because we know that there is a risk of development, a huge risk of development of deep vein thrombosis, and a person cannot be expected to walk immediately after any major surgery. Therefore, intermittent pneumatic compression stockings would be put on the legs of this person. They are gonna squeeze the calf muscles, and therefore the chances of deep vein thrombosis would be minimized. Obviously, along with this, I'll be using low molecular weight heparin. I'll be giving enoxaparin to the case, but over and above enoxaparin, intermittent pneumatic compression stockings are used to reduce the incidence of deep vein thrombosis and thereby minimize the chances of your patient or client ending up with pulmonary thromboembolism. I would also like to take or mention name of Serena Williams. You would be aware that Serena Williams is a Grand Slam champion. She plays lawn tennis and she represents USA. And Serena Williams has been a champion for so many years, almost for last previous 1 decade. Whether it be a French Open, Australian Open, every tennis match she's, or whether it's gonna be any kind of match, whether it be Olympics. I mean, she's always been winning medals or always been winning trophies. But Serena Williams, after her delivery, suffered from pulmonary embolism. Why I'm explaining to you that is because if a champion of lawn tennis, because to play lawn tennis for 10 consecutive years, you need to be physically very strong and very fit. And if a very fit lady like Serena Williams can develop pulmonary embolism, then you can understand that if an ordinary person will develop it, he's gonna suffer even much more, in a sense that a fit person can still handle medical emergency or medical illness, or is able to cope up with medical illness relatively better. Here you can see a screen grab from CNN channel which mentions about Serena Williams opening up and discussing her deep vein thrombosis that she suffered. I mean, she's described in her own words, like she noticed that her one leg was looking bigger in size as compared to the other. That is one of the features of deep vein thrombosis. And though she told it to a gynecologist before they could actually intervene, there was a clot that developed. I mean, the clot had already formed in the deep vein and it spread retrogradely to her lungs, causing extreme amount of breathing difficulty. And she was saved. But the point is, if a tennis star, or I can say a huge celebrity, can be having this and doctors were not able to identify it in time, then you can understand the importance of studying this topic and why it is asked to you in your exams. And you can also notice that blacks anyway have higher cardiovascular mortality, no? I mean, black people would be having higher chances of hypertension, higher chances of coronary artery disease, and even possibility of development of pulmonary thromboembolism. And when these words, we'll now focus on the risk factors for development of why would a person develop deep vein thrombosis and subsequently development of pulmonary embolism. You see, this that I say next would be a recap from surgery. You are all aware of Virchow's triad, where there would be one endothelial damage. I'll not write that endothelial damage because I mean there are three components of Virchow's triad. There's an endothelial damage, there is alteration in blood flow, sluggish circulation, and then there is hypercoagulability. I'll repeat that again. I'll not write it because you know it from surgery. Endothelial damage, along with that, there is sluggish blood flow, alteration of blood flow, and hypercoagulability constitute Virchow's triad, and therefore there can be development of clots. I mean, which are the veins that would be involved in deep vein thrombosis? The clots could be developing in the soleal veins, or in the popliteal veins, or in the ileal veins, and therefore closer larger is the caliber of the vein, or closer is the vein to the heart, bigger will be the size of the clot that can spread retrogradely and can cause blockages of the pulmonary artery main trunk or the branches of the pulmonary artery, and therefore breathing difficulty can be experienced by our case. Now, why would somebody end up with this clot? Then one of the plausible reasons for that could be immobilization. By immobilization, I mean complete immobilization. That person is not being able to even get up from the bed and even go to the bathroom. This chap might have undergone any major surgery, joint replacement surgery, cancer surgery, or maybe he just had an accident while crossing the road. A biker had hit him, or maybe a car had hit him, and he had multiple soft tissue injuries and a couple of fractures as well. A person after a fracture, maybe in his leg, maybe on his tibia, cannot be expected to do weight bearing. So this guy is lying down, and I want to tell you that immobilization for as little as 72 hours. I'm not talking about immobilization for weeks altogether. I'm saying immobilization for as little as 72 hours increases the risk of development of deep vein thrombosis, and the clots can spread retrogradely towards the heart. Another risk factor can be surgery. I mean, any kind of surgery. It could be major surgery, cancer surgery, orthopedic surgery, joint replacement surgery. Surgery in the previous 4 weeks is again an important risk factor for chances of development of pulmonary thromboembolism. And in the later part of this discussion, I'm going to teach you clinical decision rules. In those clinical decision rules, these statements will come up once again. Immobilization, or he might not mention the duration. He might just say prolonged immobilization, or surgery in previous 4 weeks. These could be opening lines of a question. Person had undergone cancer surgery. Maybe this was a lady who was having a cervical cancer or gynecological cancer, and then post-surgery, there was increased chances of her having deep vein thrombosis. There was asymmetry in her legs developing, and then the clot went towards the heart, and all hell breaks loose because she develops breathing difficulty. He can develop chest pain, and I'm going to teach you subsequently what will be the workup for diagnosis of pulmonary thromboembolism. Having said that, it is important for us to study the risk factors which are going to contribute to a situation of pulmonary thromboembolism and deep vein thrombosis. Then one of the important risk factors which you must remember is cancer, because all cancers, it's not only blood cancer I'm talking about, all cancers are hypercoagulable state. So if a question himself mentions that this person has undergone cancer surgery, or this is a lady with SLE, or like lots of time antiphospholipid antibody syndrome may be occurring even without SLE also. So every time you read about antiphospholipid syndrome, you would be remembering from your rheumat session that there are antibodies present here, like lupus anticoagulant antibody, or there would be anti-cardiolipin antibody, anti-beta-2 glycoprotein antibody. These antibodies which are found in antiphospholipid antibody syndrome, what they basically do is, I mean, the problem with antiphospholipid antibody syndrome is that these antibodies will cause the intrinsic system of clotting to go into automatic mode. You see, in our body, when there is some trauma, some injury, that is when clotting cycle is initiated. While I'm sitting on a chair at the moment and talking to you, or you are sitting comfortably in a house or lounging comfortably and listening to me, I mean, you are not developing clots in your body, but these patients would be. Imagine this patient sitting in a lounge, sitting on a couch, and is developing clots because their clotting cycle goes into automatic mode. The reason for that being antibodies which activate the clotting cycle, and therefore cancer and antiphospholipid syndrome are two big red flags which tell you in the question right away that he's trying to guide you towards pulmonary thromboembolism. Over and above this, other traditional risk factors that I'm going to write in part number 2 are the ones that you read even for atherosclerosis, for myocardial infarction. So if anybody is having diabetes mellitus, if his LDL cholesterol is elevated, I mean, these are risk factors that we traditionally study with the topic of atherosclerosis, but the same things are what I'm saying at the moment. Anytime he talks about a obese individual or a metabolic syndrome patient and then he underwent a surgery. So it is not that sometimes there might be only one risk factor present. It could be more than one also, like a person is obese or is having metabolic syndrome and then he or she had to undergo any kind of cancer surgery, then the risk of chances of development of pulmonary thromboembolism would be highly amplified. In fact, at this junction, I would also like to say that prolonged air travel is a big time risk factor for patients of pulmonary thromboembolism or increases the risk of chances of pulmonary thromboembolism. If you have ever taken a long distance flight, like one of the longest long distance flight from India at the moment is from Bengaluru to America, and that's about a 17-hour flight of that goes all the way over Russia and then lands up in America in 17 hours. And if you've been on a long distance flight, intermittently there are announcements that okay, you can get up and move around in the air. I mean, normally, on an Indigo flight, they don't allow you to get up and walk around because it's a short haul flight. But on a long haul flight where person is going to be sitting for long duration, there can be chances of development of clots. So intermittently they say, okay, now the gallery, you can move around if you want. And even then there would be pre-recorded announcements being made that, stretch your legs a bit or just move your ankle, move your calves a bit. Because if somebody is having metabolic syndrome and is taking a long distance flight without the advice of a doctor, there's a possibility that by the time the flight lands, this person might develop clots in his soleal vein. And while he deboards the plane, goes to the immigration counter, while he's walking, the clot could be dislodging from the soleal vein towards the heart, and then this person can develop features of pulmonary thromboembolism and breathing difficulty. So the message is that, in fact, Harrison has written two things. One is written that prolonged watching of television, and that was from a Japanese study. Prolonged watching of television, that's also immobilization, or long distance air travel are very significant risk factors that amplify the chances of development of pulmonary thromboembolism in a patient. Having said that, make no mistake, it might even be opening line of the question saying a known case of inflammatory bowel disease or rheumatoid arthritis or psoriasis. So apart from the traditional, I can say, atherosclerotic risk factors that I have currently explained to you, over and above the atherosclerotic risk factors, even point number 3 is worth its weight in the exam. And then I would like to mention regarding a couple of hypercoagulable states. This hypercoagulable state that I'll explain to you is even taught in your pathology, and I can say that this particular case, if they take a long distance flight, there is a big time problem. Like for example, this condition is called as factor 5 Leiden mutation, and in fact these people might have had a DVT episode even previously. I'm not saying that only after delivery DVT can occur. In these patients, the autosomal dominant condition that we're talking, factor 5 Leiden mutation, even post without a delivery, like this is a young unmarried female, she ended up with developing a DVT, and luckily last time she did not have a pulmonary embolism, but this time she can. Well, what is the problem in factor 5 Leiden mutation is that in our body, factor 5 and protein C, factor 5 and activated protein C are able to keep its activity. I mean, both of them are able to balance each other and they're able to keep each other's activity in check. But as such, in factor 5 Leiden mutation, there is a resistance of factor 5 to bind to protein C. So I'm just putting a negative mark here to say that factor 5 Leiden mutation basically means resistance of factor 5 to bind to protein C, and therefore protein C will not be able to keep the activity of factor 5 under check. If you're not able to control the activity, factor 5 activity is unchecked, there would be increased chances of clot formation. Similarly, there's another prothrombotic state that you should be aware of. I mean, pregnancy is a hypercoagulable state, everybody knows. So he's not going to give you pregnancy-based scenario only. He might mention factor 5 Leiden mutation per se in a question, or he might mention regarding prothrombin gene mutation. Again, in prothrombin gene mutation, the problem is the blood levels of prothrombin are higher as compared to normal individuals. So these are two hypercoagulable states that I have described, and these people and patients of these hypercoagulable states would be having increased incidence of recurrent. Earlier I was saying only massive pulmonary embolism or thromboembolism, or I said submassive pulmonary embolism. I added one word, recurrent pulmonary embolism could be developing in these patients. Then comes the issues of OCPs, not the current ones, but the older generation of OCPs that were having estrogen in high amount. You're aware that the current OCPs or combined oral contraceptive pills would be having estrogen less than 30 microgram, but the older generation of OCPs that were available used to have a higher incidence or chances of a hypercoagulable state. Then I've already explained that during pregnancy, even you study that in OBGY, fibrinogen values are elevated, so it's anyway hypercoagulable state. Then if there is a postmenopausal lady and the gynecologist has decided to start her on hormone replacement therapy, which means that estrogen would always be there, and estrogen in any amount more than 30 mics increases the hypercoagulable state. Then COVID-19, the spike antigen of SARS-CoV-2 virus causes hypercoagulable state. All of you would have written D-dimer assay test for your COVID-19 patients. It was always elevated because the spike antigen COVID-19 contributes to pulmonary embolism. In COVID-19, we lost a lot of patients to pneumonia and ARDS, but we lost a lot of patients even to MI and even to pulmonary embolism because COVID itself is a hypercoagulable state. And then one more hypercoagulable state that I would like to mention at the moment is nephrotic syndrome. Nephrotic syndrome per se is a condition where fibrinogen values would be elevated. I mean, in nephrotic syndrome, low molecular weight proteins are lost, but high molecular weight proteins like fibrinogen are not lost, and therefore fibrinogen values are elevated. And along with that, in nephrotic syndrome, one more reason for hypercoagulable state can be that if nephrotic syndrome is that of non-selective proteinuria, then there can be even a urinary loss. Traditionally we read about urinary loss of albumin. Look at the surprising thing I'm teaching you, that in nephrotic syndrome, there can be urinary loss of protein C, protein S, and antithrombin 3. In our body, we have a clotting cycle and we have an anti-clotting cycle. If you lose anti-clotting system from the body, then clotting cycle will be unchecked. And therefore, when you read nephrotic syndrome in kidney, I have said it is a hypercoagulable state. So at this moment, what I've tried to do is, in these 5 points, I've tried to tell you the opening few words of the case-based scenario pulmonary thromboembolism. He might begin by describing patients undergone a cancer surgery. Or you might begin by saying a obese individual has undergone a cancer surgery, or it might be routine orthopedic surgery or non-orthopedic surgery. But considering all these, or inflammatory disease patient has undergone any operative procedure, and post that there is a breathing difficulty. So these are like the opening lines. These are the risk factors which cause increased chances of clots in the body. And once we studied them, we will now focus on lung physiology. What's going to happen to the patient from the physiology perspective. The first and the foremost thing to be remembered would be a change in the alveolar arteriolar gradient, and the alveolar arteriolar gradient is written as A minus A. The capital A would be the partial pressure of oxygen in our alveoli, that is P capital A O2, but at the same time there is a small a O2 also. That small a O2 will be the partial pressure of oxygen in the blood vessels which are going to be surrounding the alveoli. Like, let me say this capital A is the alveoli, and the small a will be for the blood vessels which are surrounding the alveoli, and therefore I've written two A's here, and the gradient between the two in a normal person is between 5 to 15 millimeters of mercury. Now, what happens in patients of pulmonary embolism is that because the blood vessels get blocked, oxygen would not be transported. Oxygen is reaching the alveoli, it is okay. But the small a value will be lesser because there is no blood reaching this area. So therefore, mathematically speaking, I'm saying that capital A is the same. Capital A is the same. The normal value is there, but the small a value is lesser. And if you look into a bit of mathematics, like if the initial value is the same, but the small a value will be lesser, then mathematical output will be more than the normal range that I've described. And that was from the lung physiology perspective, increased alveolar arteriolar gradient. Increased alveolar arteriolar gradient has been described separately also with respect to flow volume curves, where I've described flow volume curves in obstructive airway disease, restrictive airway disease. There I've also focused on alveolar arteriolar gradient as well. Now, the second issue that will occur is because there is blockage of pulmonary vessels. So oxygen is ultimately not getting access properly to hemoglobin, and therefore I can say the dead space. Every time in physiology we read about dead space, like if we breathe in 500 ml of air, all 500 ml does not reach the alveoli. We have only about 350 ml reaching the alveoli. Remaining air will remain in the trachea only. That is called as dead space. So we have an anatomical dead space, we have a physiological dead space. And in pulmonary thromboembolism, this dead space would be increased. And that again explains the fact that why there is a hypoxia in the body. I said the reason for hypoxia would be one, the blood, there is a perfusion defect. Blood is not reaching these blood vessels because there was a main, or there could be single clot, it could be more than one clot occluding the lung vasculature. Like in massive pulmonary embolism, more than 50%. I mean, huge value I'm saying, no, in massive pulmonary embolism, more than 50% of the lung vasculature can be affected. So since the blood is not reaching there, so I can say overall the dead space is increased. There would be a defective oxygenation occurring in this body, in the body of this patient. And every time there is a hypoxia, hypoxia causes pulmonary vasoconstriction. Guys, hypoxia causes dilation of all other blood vessels in the body except pulmonary artery. Pulmonary artery or pulmonary vessels rather do not dilate in response to hypoxia, they rather exhibit a constriction. The reason for that I can say is pulmonary artery is the only artery carrying, it doesn't carry oxygen, no. Pulmonary artery carries carbon dioxide. So behavior of pulmonary artery or its vessels or branches is different from all other vessels. The basic statement of physiology to be remembered by you is all blood vessels dilate in response to hypoxia. All blood vessels dilate in response to hypoxia except pulmonary vessels. Pulmonary vessels will not dilate, they will rather constrict, and therefore pulmonary vascular resistance will be more. So now there is more problem because one, blood supply is less, and if the blood vessels are constricted, blood supply will be further more lesser. This will contribute to your patient breathing harder than normal. Therefore, respiratory rate in all patients of pulmonary thromboembolism is increased. I mean, though this person is lying on the hospital bed, he's undergone some surgery, but he'll be breathing so fast and it would be sudden onset breathing difficulty that it would be as if he's run a half marathon. So alveolar hyperventilation is present. You can see from the physiology perspective, everything is, the arrow for that is going up. That is like alveolar arterial gradient is more, anatomical dead space is more, pulmonary vascular resistance is more, breathing rate is also more, respiratory rate is more. What is less is that your answer would be pulmonary compliance. Traditionally, we read about reduced pulmonary compliance with lung fibrosis, but today, because there is a perfusion defect in the heart, we would still call it reduced pulmonary compliance. So these pointers that I've written here before you, because it's integrated kind of questions, one option could be from the risk factors perspective. Or he could ask component of virtual stride. I mean, that could be one of the contributors to development of pulmonary thromboembolism, which I described. Three of them I'm going to make you practice again. I've deliberately not written them and would not like them to be present in printed notes also, because this you should know from surgery. Endothelial damage, alteration of flow, and then hypercoagulability component. And the most important statement I can say for this particular slide is cancer is a hypercoagulable state. All these are risk factors for development of pulmonary embolism, and because we know that these patients can have pulmonary embolism, ideally in all of these patients there should be administration of low molecular weight heparin, enoxaparin, post-operatively in any patient undergoing cancer surgery, even orthopedic surgery, sometimes even non-orthopedic surgery. We give low molecular weight heparin injections. That would be once a day only, with adjustment for renal malfunction if it is present. But our objective is to minimize the chances. This is, guys, a preventable illness. It is a preventable cause of death. And once we've understood these risk factors, we'll now be focusing on the hemodynamics and what's going to happen to the pulmonary blood flow. So this is it. What happened? There is a huge clot which I've shown symbolically occluding one of the branches of the pulmonary artery. And the moment there is a obstruction present here, therefore the blood supply to the distal lung segment would be compromised. That is development of pulmonary oligemia. You can see that blood supply to one lung here in this hypothetical diagram looks okay, but the blood supply to the contralateral lung or some part of the lung is getting severely hampered. Now, because of the obstruction caused by the clot, the pressure in the pulmonary artery will begin to rise. So this person will start developing pulmonary artery hypertension. And just for symbolic reasons, what I'm going to do is that I'm going to show a dilatation of the pulmonary artery. The reason for this is simple, I would say, physics, that wherever there is an obstruction, then proximal to the obstruction, the pressure begins to increase. And therefore, I have said the person will start developing sudden onset pulmonary artery hypertension. If there is a sudden onset pulmonary artery hypertension, it will also contribute to development of right ventricle to work harder against this increased pressure. And therefore, the right ventricle of this patient will begin to fail. And therefore, in persons who are having pulmonary thromboembolism, we get right ventricular failure. Because of this right ventricular failure, when you will check out the JVP of this person, the JVP will always be elevated. And normally, JVP always falls on inspiration. It falls because our heart is able to relax, it is able to dilate, but here the heart is failing. The symbolic diagram here shows right ventricular failure, and since the heart is already dilated, already congested, because blood aage ja nahi raha, blood is not going forward because there is an obstruction. So in this person, unlike a normal person, when you ask him to take a deep breath, normally on deep inspiration, what we get is a JVP column to fall. But in this person, what is happening is on deep inspiration, the JVP column is rather rising, and that is what is called as Kussmaul sign. This description that I'm giving you is for a case who's having a clot occluding one of the pulmonary artery or maybe a branch of the pulmonary artery. This is only the starting of the problem. When I say that, people say, sir, already so much is problems are there, pulmonary artery hypertension, right ventricular failure. I'm saying this is only the starting of the problem. See forwards what happened. Aage dekho, the obstruction here is so, it's like a fixed anatomical obstruction present here. So the pressure will keep on increasing to the level that now what I'm showing is a grossly dilated right ventricle. In fact, not only have I shown a grossly dilated right ventricle, I have also modified the diagram to currently show before you, which is an event that happens in cases of massive pulmonary embolism, that is interventricular septal deviation. Because blood cannot go in a forward direction, so even the septum is bulging in one side. See, right ventricle is a weak pump. Left ventricle is more takatwar, it is more powerful, so it can still push blood in a forward direction. But right ventricle has less muscle, it is not so powerful, so the poor fellow will dilate and fail. And because of this septal deviation, the left ventricular end diastolic volume, you can see the cavity size of the left ventricle will become smaller. If the left ventricle will receive less blood, then less will be going out. If less will be going out, the cardiac output will decrease. If cardiac output will decrease, the blood pressure will decrease. And if blood pressure will decrease, mean arterial pressure will fall. That will also cause a reduction of coronary blood flow. Guys, the condition that I'm describing before you at the moment is technically called as acute cor pulmonale. And before I just jot down the sequence of events or make you practice these events once again, I want to draw your attention to the fact I have spoken about it earlier, but I would just like to say this once again. If they simply say what is the leading cause of cor pulmonale, if the MCQ simply says what is the leading cause of cor pulmonale, your answer would be cigarette smoking, that is COPD. Meaning of the word cor pulmonale is right ventricular failure due to non-cardiogenic cause. You see, at the moment there is a clot which is developing in the legs and then is going via the heart. It is not starting in the heart, it is going via the heart into the lung circulation. So I've written meaning of the word cor pulmonale is right ventricular failure due to non-cardiogenic cause, and the usual reason for cor pulmonale is hypoxia caused by COPD, which causes pulmonary artery hypertension, and pulmonary artery hypertension then causes right ventricle to become decompensated. But currently we are studying regarding acute cor pulmonale. The reason for acute cor pulmonale is the topic of interest that we are studying. That would be answered by US, though I could have written pulmonary embolism also, but the technically more appropriate term would be massive pulmonary thromboembolism. You see, you could be having non-thromboembolic causes as well. Like you read about amniotic fluid embolism, fat embolism, bone cement. After orthopedic surgery, there can be bone cement embolism as well. So traditionally, we read both about thromboembolism and non-thromboembolism also. Example of non-thromboembolism, I'll say again, would be like amniotic fluid embolism, or bone cement embolism, or it could be air embolism, fat embolism. Those are non-thrombotic embolisms, but currently we are talking about massive pulmonary thromboembolism. This is what happened. There was a big clot obstructing the pulmonary artery. So I wrote pulmonary oligemia as the initial event, which will explain the breathing difficulty. See, with one lung, you cannot maintain proper oxygen saturation. One lung blood supply is getting seriously compromised. So I am exaggerating, right? One pulmonary artery branch is blocked. Clot may not be so big. It may be a little smaller, so it will go more distally. If it's even more smaller, it will go more distally. It could be shower of emboli. It could be more than one clot as well. So we can't predict how many clots would be going in the lung circulation, but the end result of this is that if you're having a blockage of the main pulmonary circulation, there would be a sudden onset pulmonary artery hypertension. Because of this sudden onset, there is a hypoxia already occurring because blood supply to lungs is hampered, but there is a pulmonary artery hypertension suddenly, then there is going to be a right ventricular failure. And because of this right ventricular failure, what will happen is that because the right ventricle wall is getting distended, so there is a significant amount of tension in the wall of the heart. I'll say that again. You see the shape of the right ventricle of this patient is grossly dilated. It is totally stretched out. So therefore I've written the tension in the wall of the heart is increased, and due to this increase in the tension of the wall of the heart, it will squeeze its own blood vessels. Because it will squeeze its own blood vessels, the coronary blood flow of these patients will become lesser. And if coronary flow will become lesser, it can explain the chest pain that would be occurring in these patients. It can also explain the decreased cardiac function, cardiogenic shock that can do, because coronary blood flow, if heart will not get oxygen by itself, if heart will not get its own supply, then it will not be able to function properly, and therefore cardiogenic shock can occur in these patients. In fact, sometimes because the coronary blood flow is impacted in these patients, there can be a development of right ventricular microinfarction, and therefore do not be surprised that in the later part of the clinical discussion, at the moment we're studying pathophysiology and the lung dynamics, but in the clinical feature, I will be saying person is having elevated troponin I, elevated troponin T, elevated heart fatty acid binding protein. Why? Because there is microinfarction. Why there is a microinfarction? Because blood supply to the heart itself is lesser, because the heart is dilated, it is stretched, and therefore the grossly dilated heart, the increase in the tension of the wall of the heart squeezes its own blood supply, and therefore right ventricular microinfarction could be occurring. This is just the starting of the event, guys. Pulmonary arterial hypertension, RBF microinfarction is just starting. The most dangerous event that is occurring in this person of massive pulmonary embolism is the septal deviation, where the interventricular septum is bulging into the cavity of the left ventricle. Therefore, rest is history. I mean, if the cavity of the left ventricle will be relatively smaller, then it will be able to receive less amount of blood. If less will come in, less will be going out. If input is lesser, output will also be lesser, which explains why hypotension will occur. And guys, the surprising thing that I'm teaching you is that problem occurred in the right side of the heart, but BP is falling on the left side, no? I repeat that again. Problem occurred in the right side of the heart, and BP is falling on the left hand side. So how is it possible that the blockage is occurring here, BP is falling on the left? One simple logic is, if blood will not go in the lungs, then less will come to the left side. See, blood will go into the lungs and come to left side. If blood will not be able to go to lungs, then less will be coming in the left side. And if less will come in the left side, if I show like this dotted, less blood coming in, then BP will be less, coronary blood flow will also be hampered. Over and added insult, I can say, is the interventricular septum showing a exaggerated deviation, and this can be picked up radiologically also. We have a sign present here. That sign that we see, in fact, let me just sensitize you to the clinical sign here only. The septal deviation is occurring. You can also notice that there is a gross change in the shape of the right ventricle. I mean, look how distorted it looks like. So therefore, another term which I want to bring to your attention is called as McConnell sign. McConnell sign description I will be giving you in the later part of this slide when I talk about the workup. At the moment, all I can say is, because of the distortion of the shape of the right ventricle, the right ventricular contractility will be less. So in the later part of this discussion, you will see me writing the word right ventricular hypokinesia, because of the change. Shape of the heart is everything. If you have a change in the shape of the heart, the contractility part is hampered, and therefore in the later part of this video, you will hear me saying words like RV hypokinesia, that is McConnell sign. This was an FMG exam question. McConnell sign is seen in, simple one liner. McConnell sign is seen in, the answer is pulmonary thromboembolism. And because of these micro infarctions that occur, I mean, this is the reason why, no big deal that in the question trop I can be elevated. You might start thinking you are dealing with a case of inferior wall MI, because heart fatty acid binding protein or cardiac biomarkers are getting elevated. So that can cause a misdiagnosis with myocardial infarction. That is one of the common problems that we see with this particular disease, because see, even MI will have breathing difficulty. MI will have chest pain. Even in this condition, there is a breathing difficulty and chest pain. So after a few minutes, I'll be able to teach you, I mean, on the basis of the case-based scenario and the hemodynamics, I'll be able to, on the clinical findings basis, I'll be able to teach you that, okay, how do we pick up whether it is a case of MI or whether it is pulmonary embolism. And lots of time, experts also make a diagnosis, which is why a particular workup for diagnosis of this condition happens to be discussed still. And that workup that I teach you subsequently will be one of the most critical parts of this discussion. Let's focus at the things that we've learned till now before I go and discuss a case-based scenario. The opening line of the question will usually talk about risk factors ranging from any active cancer to inflammatory bowel disease to atherosclerotic risk factors, nephrotic syndrome, and even mention things like, this person took a long distance flight, or this person had some major surgery, or this person gave birth to a baby. This lady gave birth to a baby. She's a known case of antiphospholipid syndrome, and there could be hypercoagulable state like factor V laden mutation. I mean, any of these could be the opening line of a question, and then there is going to be sudden onset. The words are going to be sudden onset breathing difficulty and chest pain. I'll give you the reason for chest pain. One is very clear, that this condition causes its own coronary blood flow to be lesser because of two reasons. One, there is decrease in blood pressure. If less blood will go out of the heart, less blood will go into coronary arteries also. And the second reason is that stretching of the wall of the right ventricle squeezes its own blood supply, the smaller branches, and therefore micro infarctions in the right ventricle can be seen. Another two important messages are leading cause of cor pulmonale COPD. Leading cause of acute cor pulmonale, the answer would be the topic that we're studying, pulmonary thromboembolism, and most of the time it's going to be massive pulmonary thromboembolism. The case scenario that I'm going to describe before you is of a senior citizen. He's 75 years of age, and in the orthopedics department, he has undergone a bilateral total hip replacement. You would have noticed that after COVID, the requirement for joint replacement surgery has increased. Why? Because at COVID times, we were using indiscriminately large amount of steroids, methylprednisolone, then prednisolone, and all those patients who had taken steroids for that long duration, we are seeing that those patients are now coming to us in 2024 with avascular necrosis of the head of the femur. So considering the fact that this chap had developed, unfortunately, bilateral avascular necrosis of the head of the femur, is undergone a total hip replacement bilateral in the orthopedics department, the surgery went perfectly fine. There was no surgery. I mean, intraoperatively, there was absolutely no problems. And now it is day 3 post-operative. It is 8 p.m. in the evening. I have taken my rounds and I'm going back to my car in the parking lot when my nurse had called me, and she's telling me that this old man on a particular bed is complaining. He was pressing on the call button again and again. So the nurse went to the bedside and she noticed that this man was trying to signal with his hand that he's not getting breath. So she is calling me and she's saying that, sir, this patient was perfectly fine a couple of minutes ago. And while going back into the recovery unit, I'm also thinking to myself that I had spoken to this man. This old man was talking to me and he was saying, when would you discharge me? And I told him that it's the orthopedician who will decide. I'm only to take care of the medical component. And because, this particular chap is in a hospital where we do integrated care. So per se, I can say now is having breathing difficulty, and there might even be chest pain experienced by this person. I'll explain the reason for the chest pain also. But at the moment, considering the symptoms of this guy, I'm suspecting 75-year-old man, it could be myocardial infarction. I mean, that's one of the leading differential diagnosis. So I decided to go in for examination of this chap. When I checked the vitals chart, I noticed that the heart rate of this person is suddenly shot up. I mean, before, let me say at 7 o'clock in the evening, the heart rate was fine. At 8 p.m. in the evening, it's suddenly up to 120 per minute. When I checked the blood pressure by myself, I did not rely on the charts. I noticed that it was only 90 by 60 millimeter of mercury and is falling fast. I am also noticing that his neck veins are full. His jugular venous pressure is elevated, and in a normal person, the JVP should begin to fall on inspiration, but in this guy, it's not falling. Rather, it is rising on inspiration. That is presence of Kussmaul sign. So I know there's something wrong with the heart of this patient, and I'm mentally preparing myself to handle ST elevation or a non-ST elevation MI or acute coronary syndrome. When I auscultated this guy, I found he was having loud S1. Now that is no big deal because loud S1 is always a feature of tachycardia. But when I auscultated the second heart sound of this person, second heart sound is going to be aortic and pulmonic valve closure. And we have discussed in a regular cardiovascular class that the time lag between the closure of the aortic and the pulmonic valve is 30 milliseconds. First aortic valve closes, then pulmonic valve closes, and the time lag between the closure of the two is 30 milliseconds. Now, if a person will have right ventricular failure, because see, in pulmonary embolism, ultimately clot is stuck in the branch of the pulmonary artery or the main stem of the pulmonary artery. So therefore, right ventricle will fail. So I want you to think logically and tell me that if right ventricle is failing, then exit of blood from the right side of the heart, will it take normal time or will it take extra time? And I'm very sure you would be on the same frequency with me that if the right side of the heart will fail, then blood will take more time to go out of the heart. And because exit will take extra time, what will happen to pulmonic valve closure? The pulmonic valve closure, I give you two options. Will it be on time closure or will it be a delayed closure? And it cannot be on time because blood is going to take more time to go to the heart. So therefore there would be a delayed closure that would be occurring. And because of this delayed closure part, now you can see that the gap between the aortic and the pulmonic valve closure has increased dramatically. And therefore one of the hints in the question could be that he could mention regarding a wide split second heart sound. You need to anyway remember this for your exam, that anytime in your career, if you're gonna read this word narrow split second heart sound, you will think in terms of left ventricular failure. Though there are a lot of causes of narrow split second heart sound, but the minimum that you're supposed to remember is narrow split second heart sound is left. And when you read wide split second heart sound, you are to think in terms of right ventricular failure. Over and above this, you need to remember wide fixed split. Listen to this word carefully, wide fixed split. Traditionally in pediatrics, you know, wide fixed split is going to be for ASD, but I'm going to teach you wide fixed split for even patients of pulmonary thromboembolism. Next, I'm going to invert my stethoscope and I'm going to use the bell to hear the third heart sound, because ventricular gallop is always present in heart failure. And when you will auscultate this person, you will notice that bilateral lungs would be clear. Initially, I was anticipating that this guy would be having crepitations in bilateral lung fields, because usually if it is the anterior wall MI, it causes left ventricular damage and therefore person could be having crepitations in both lung fields. But this patient's lungs were clear. And in fact, this was itself a question in the previous year exams where the following options were given. He said, which of the following is not correct about pulmonary embolism? And in the fourth option, he had written bilateral crepitations in the chest. Bilateral crackles or crepitations are seen in left ventricular failure, whereas in this topic, which is the ventricle that is getting affected? Right ventricle. If you've forgotten it, I'm just going to show you this diagram. You can see the right ventricle getting impacted, which is responsible for this wide fixed split second heart sound. And the lungs are clear because crepitations, I repeat again, are a feature of left ventricular failure. And therefore, I will be writing on the case file that I'm dealing with a query, pulmonary thromboembolism. I'm writing the word query because I have still not done ECG. I have still not at the moment done other specific tests which are required to confirm the diagnosis. But the way the question is given, it talks about immobilization, because after joint replacement surgery, old people anyway take time to recover. And because this patient was bedridden, there could have been clots developing in the pelvic veins or maybe in the femoral vein, popliteal vein, soleal vein. I mean, the closer they are to the heart, the bigger they will be in size, and therefore they would have gone in the lungs of this patient, contributing to this catastrophic event. Now let's look at the clinical decision rule, which will help you be sure clinically that, okay, I'm dealing with pulmonary embolism. Now, the mnemonic that we use to remember this would be BDC and BDC hip. And out of this, the first component that I'm going to write is not very common, but can be present in some cases, which is a very dramatic symptom of hemoptysis or blood in the sputum. You see, the logic is that if there is going to be obstruction of the pulmonary artery or its branches, then the pressure proximal to wherever the obstruction is present is going to rise, and that can cause those branches to pop off, and that is why hemoptysis can be explained. So blood in the sputum is though a rare feature but is included in the clinical decision rule for pulmonary embolism. The logic is simple and straightforward. Whenever you have obstruction, proximal area, there would be dilatation and the blood vessel can pop off. Alphabet D would be for deep vein thrombosis. Now, deep vein thrombosis can be having signs. In the sign, I can say that person could be having Homan sign. Homan sign means that if you do a passive dorsiflexion of the ankle, it will cause calf pain. Plus, there might be asymmetry between the two calves of the patient. Whenever there is deep vein thrombosis, there would be asymmetry of the limbs present. So, deep vein thrombosis signs and symptoms would be present. Symptom will mostly be a vague, non-specific calf pain. I mean, like this lady underwent a delivery or an old man underwent an orthopedic surgery. So in the legs of this person, there is a vague calf pain, but on ankle dorsiflexion, the pain is accentuated. There is asymmetry of the calf muscle. So that tells you that, okay, there is a event prior to pulmonary embolism, which is DVT. Then, as I've explained earlier, all cancers are hypercoagulable states. So in BDC, the parameters to be taken are blood in the sputum, DVT signs, and cancer. Each of these signs is given specific or is allocated special points. You don't need to remember all of them, but at least DVT sign is given 3 points. Like other pointers would be like 1 point or 2 points that are given, but DVT sign and symptoms, because that's the trigger, so it is given higher allocation. I mean, in any scoring, no, whatever parameter will have more contribution will be given a higher score. Then H would be relatively easier to remember. That is, there would be tachycardia. The heart rate of this person is more than 100. Alphabet I would be standing for immobilization. As I've explained right in the beginning of this video, that you don't need immobilization for like 1 week, 2 week, and that is when the clots will develop. Studies have shown, and in practice also we have seen, that immobilization for as little as 72 hours can result in development of pulmonary embolism. That is okay. That if any person has undergone surgery in last 4 weeks, then I mean any major surgery is what I'm talking about, not a minor OT procedure, but anybody who's undergone a major surgery in the last 4 week period is again at risk for development of pulmonary embolism. And alphabet P would be standing for prior incidents. Like lots of time we have hypercoagulable states. So if anybody is having a hypercoagulable state, the incidence of this would be that there could be a subsequent event occurring in a person also. So if there is a prior DVT event or a prior pulmonary embolism event in a person, then this is again given 3 points. So overall I can say that most of these parameters would be having 1 point. Like blood in the sputum is rare, or not everybody is having a cancer. And tachycardia is not a very specific thing. Tachycardia can occur in you and me also due to anxiety. So 3 pointers are given for only 2 things, and both are having DVT. Either is currently having DVT or there's a prior episode of DVT. Listen to the points again. Either it is current episode of DVT, or it is a prior DVT event or pulmonary embolism that the person has suffered from. And he says that if the total score of a person is more than 4, then there is a high likelihood of development of pulmonary embolism. This that I've currently explained to you is the clinical decision rule for pulmonary embolism. I mean, if these parameters are present, like in the case that I discussed, I deliberately did not mention about any cancer, or did not mention that would have made it easier for you. Suppose I started by saying a lady is having any ovarian cancer, right? And she's a known case of ovarian cancer. She is scheduled for total abdominal hysterectomy with bilateral salpingo-oophorectomy, and post-surgery she's having these events that I've described. Then it would be relatively easier for you. So I decided to deliberately introduce something like a joint replacement surgery for avascular necrosis of the hip, and you will have to use your clinical wisdom on basis of BDC hip, blood in the sputum, DVT signs and symptoms, then cancer, heart rate, immobilization, prior episode of DVT is what I've said. And while focusing on these, do not fall in the trap of the examiner. A lot of these app wallahs, what they'll do is that these apps will put up clinical decision rule, but not for pulmonary embolism. They might start asking you clinical decision rule for deep vein thrombosis. You see, we have what is called as well score. I mean, we always read about well score with respect to, deep vein thrombosis and subsequent pulmonary embolism. But in a lot of these apps, you will notice that he'll ask you clinical decision rule for deep vein thrombosis. Now there are multiple parameters here, so let's just practice them each one of them one by one. Like if somebody is having active cancer, I told you cancer is a hypercoagulable state. If somebody is having paralysis, or there is a plaster immobilization lower extremity, like person was crossing the road, he's having fracture of bilateral tibia, bumper fracture, and he's having recent plaster immobilization, we have to give 1 point. Then if person is bedridden due to maybe cesarean section, there is local tenderness, there is swelling in the leg, there is calf swelling. Some of these parameters look familiar, no? Because we were discussing signs of DVT even in the clinical decision rule for pulmonary embolism. So a lot of guys fall in the trap, and the trap is that the high likelihood of pulmonary embolism is when the score is more than 4 points. But with respect to the clinical decision rule for deep vein thrombosis, high likelihood of deep vein thrombosis is present when the score is more than 3 points. I repeat that once again. There are 2 clinical decision rules that I'm talking about. They're given in a single table in Harrison, and what he will do is that because he knows that you will think about this score, the one that I've explained, BDC hip, he will start talking about the clinical decision rule for deep vein thrombosis, which is simple and straightforward. I mean, anybody who's had an immobilization, plaster-based immobilization, cancer present, swelling in the leg present, then these are the parameters, pitting edema, or there's going to be previously documented. These are parameters that have, this is a checklist. You don't need to remember all of them, but this checklist is for deep vein thrombosis. And what you need to remember is that for pulmonary embolism, high likelihood is when the value is more than 4, but for DVT, the likelihood is more than 3. And obviously, the two events are interlinked in a sense that first you have DVT and then you have pulmonary embolism. Vice versa won't be there, no? I mean, every time you first have a DVT and then you have a pulmonary embolism. But the case that I discussed before you, that was helping me. I mean, the case information that was given, some of the parameters were present. So I said it is a query pulmonary thromboembolism. And now I just want to tell you that if he says the word pulmonary infarction has occurred, pulmonary infarction would mean that there is a small clot which is causing a wedge-shaped opacity which is visible on an X-ray also. I'll be drawing a diagram of the lungs in after a few minutes from now, but I just want to draw your attention to a radiological finding. Even the radiology teacher will be saying this word Hampton hump. That Hampton hump would be a wedge opacity that is created because wherever there is a small clot which has gone in the lung circulation, distal to that there would be a development of a infarct, and that infarct would be visible as a white shadow on the X-ray. It would be associated with a lot of chest pain as well because the blood supply to the pleura will be impacted. You see, every time I've been saying chest pain. So one reason for chest pain is the microinfarctions that are occurring. But another reason why these patients can be having development of chest pain is because of pleural infarction, because the blood supply of the pleura will also be hampered. You see, pleura is in the periphery of the lung. So if a small clot, if it's a large clot, it will block the pulmonary artery. But if it is small clots and they're going into ultra chota blood vessels, small blood vessels, then these micro infarctions in the lung could also be developing. And these infarctions in the periphery of the lung, because they're close to the pleura, can explain the development of chest pain. Guys, this is what I'm saying. A patient could be having like a shower of multiple chota emboli, which could be going into the distal circulation, and they could be going and causing blockage of these small blood vessels. In this particular case, where there's a shower of multiple small emboli going into the distal circulation, I would like to use the word submassive pulmonary embolism. In submassive pulmonary embolism, because there's an obstruction, there would be increase in the pressure in the pulmonary artery. The increase in the pressure in the pulmonary artery will contribute to development of right ventricular failure. But you can see the way I've drawn the diagram. I've not shown a gross distension of the right ventricle. I've just said, okay, there will be right ventricular failure, but I've not shown any septal deviation in this diagram. You can see the septal deviation is not there in this figure. As a result of it, the cavity size of the left ventricle, is perfectly normal. And because the cavity size of the left ventricle is normal, therefore, normal amount of blood would be coming in the left hand side, and therefore the BP will not crash. You see, the current topic that I'm teaching you is submassive pulmonary embolism. Because in this condition, chota blood vessels or small blood vessels are getting impacted. So yes, there would be obstruction, there would be pulmonary artery hypertension, there would still be a right ventricular failure, but the amount of damage that I've shown on the right hand side is lesser than what I showed earlier with respect to this huge clot causing obstruction. So this diagram is for massive pulmonary embolism. And in massive pulmonary embolism, the only way to save the life of this guy is to go ahead with thrombolysis. I will obviously give anticoagulation. I will give low molecular weight heparin. I might be subsequently giving warfarin. That's a later aspect. At the moment, if I have to destroy this large clot, what I need to do is go ahead with thrombolysis. So the learning point for you guys is every time there is a massive pulmonary embolism with crashing of the BP given, thrombolysis is to be answered. Now look at this possibility where the BP will be normal. If a doctor by mistake will thrombolyze this guy, it's gonna deteriorate the case. Let me say that again. You would be shocked at the words that I'm saying. Just a few minutes ago, I was praising thrombolysis. I was saying, no, there's a crashing of BP because there's a big clot and I need to destroy it, and therefore thrombolysis should be done for massive pulmonary embolism. But now I'm teaching you that if it is submassive, how do I know it is submassive? The cavity size of the left ventricle would be normal, the BP would be normal or can be slightly lesser but will never be unrecordable. Why it is lesser? Because if these chota blood vessels are blocked, then blood supply to left side of the heart will be slightly lesser than normal, but it is not going to contribute to crashing of blood pressure. That crashing occurs because of septal deviation that occurs in these patients of massive PE. But in this case, because there is no exaggerated septal deviation or any kind of septal deviation present, so therefore crashing of BP is very, very unlikely. And therefore, we are not going to do a thrombolysis. If a doctor will do thrombolysis, their clot is already broken into pieces. If you are going to do a thrombolysis in this particular case, it will cause worsening of this particular patient. Therefore, L-teplase, which is a common drug, L-teplase has been discussed even in acute ischemic stroke. It has been discussed in ST elevation MI. Today, I am teaching you that L-teplase will be given for cases of massive pulmonary embolism. But why we don't give it in submassive is because the clot is already broken into pieces. If you break it further, it will not give any advantage. Now let's focus on the extreme right hand side where I have shown, let me say, only one clot, small clot, or maybe two clots coming in the right side of the heart. So they will be causing maybe one chota sa blood vessel getting involved or another blood vessel getting involved. And wherever this blood vessel will be involved, distal to that, there would be a infarction in the lung developing. And therefore, I repeat the statement that I have currently shown on this slide right on the top, that pulmonary infarction indicates a small, that's the statement to be remembered. Lot of guys casually answered pulmonary infarction and then answer that as large. Yep, even if large blood vessels are involved, there is bound to be damage to the blood supply. But these wedge-shaped infarcts that I'm talking about, the classical pulmonary infarctions that we see, that's with a small pulmonary embolism, and they are more painful. Why? Because the periphery of the periphery is where the pleura is, and that's where the nerve endings are, and therefore the chest pain would be present. The description that I've given for maybe one clot or few clots coming in would be pulmonary embolism. So overall, I can say it was one big, huge clot. It was shower of multiple small, small clots, and now it's like maybe one small clot going in. I'll say that again. I have tried to explain to you one huge clot going into the lung circulation. I've shown a shower of multiple small clots coming into the lung circulation, and then I've said it would be a single clot coming in. So I've subdivided the discussion into three. That would be massive, submassive, and then plain pulmonary embolism, out of which plain pulmonary embolism is likely to cause more symptoms of chest pain, whereas massive will cause more symptoms of breathing difficulty. Only clinical. Real diagnosis will be made workup only. I'll say that again. If it's a huge clot, like a saddle embolus, then hardly any blood will go to either of the lungs. So main problem would be breathing difficulty. Whereas with a small pulmonary infarction, there is more possibility of this involvement of the pleura also, because pleura is in the periphery. Like in this diagram, I can say that in the periphery, there would be pleura present here. And because the blood supply of the pleura is also getting affected, that is why there would be chest pain experienced by our case of plain pulmonary embolism. The objective was to sensitize you to the fact that if a person is having these small, small clots going in the lungs, no need for big guns like L-teplase. Only heparin is sufficient. If he says, how do you handle PE? Answer is heparin. How do you handle submassive PE? Answer is heparin. But if he says, how do you handle massive PE? Then your answer is heparin plus thrombolysis. Heparin plus thrombolysis. Thrombolysis is only to be asked for the massive variety where there's a crashing of blood pressure. Do not answer thrombolysis for the situations shown here, because the clot is already disintegrated. Disintegrating it further is not gonna give any survival benefit. This subdivision that I was explaining to you was massive, submassive, and plain PE. In about 5 to 10% of cases, it would be only the massive variety of pulmonary embolism. If he says which is the most common variety, that is plain PE, that is 65 to 75%, that is low risk, has an excellent prognosis, and submassive would be something in the middle where intermediate risk would be present. So I've subdivided this into high risk, intermediate risk, and low risk. How do you know in a MCQ? Check out the BP value. Deliberately, the BP value will be given towards the end in the vitals. Every time you have a crashing patient, or because of the crashing of the BP, he says there is blueness of lips as well as fingertips, central cyanosis developing. It will be beneficial if he will also give maybe a pulmonary angiography report where he himself says that more than 50% of the pulmonary circulation is affected. Because see, if I move on to the submassive variety or plain P, it would be hardly few percentage of pulmonary circulation affected. But if it is at least 50% or more of pulmonary circulation affected, we call it massive pulmonary embolism. The biggest problem in this case is because the lung circulation is having a thrombosis. I mean, how is the circulation affected? There's a clot, and that clot will propagate also, na? Like if there's a clot, it will increase in size, it will propagate in the pulmonary tree, and that's the reason why 50% of the pulmonary circulation has been affected. Or it could be a subtle embolus, it could be sandwiching at the bifurcation, it could be reducing the blood supply of one lung. But ultimately, the problem with this condition is that it will cause cardiogenic shock. As I explained to you, reason for cardiogenic shock I'm writing is because there was the septal deviation, the cavity size of the left ventricle was smaller, and therefore the BP was also falling in because less blood is coming in the heart, less is going out. So cardiogenic shock is a feature that we encounter with our cases of the massive variety of pulmonary embolism. Let us now focus on the submassive variety, and the highlight in this case would be that the BP will not crash. It would be usually given to be normal or slightly on the lower side of normal. Yeah, findings the right ventricular failure will be occurring in both of them. I mean, right ventricular failure is described for both massive variety as well as for the submassive variety. I can just put by plus sign saying that the magnitude of damage here will be relatively lesser. In fact, in submassive variety, there is a high probability of this being misdiagnosed as myocardial infarction because most of the time, right ventricular infarct, microinfarcts will occur even in the massive variety. But in the intermittent risk, because there are small clots which are present and they're causing that occlusion present. So one, the BP will not fall, and second, the dilation of the right ventricle or the damage to the right ventricle can be causing that elevation of biomarkers as well, which can cause diagnostic confusion with myocardial infarction. The reason for the microinfarction, as I explained, was increase in the wall tension as well as decrease in the coronary perfusion of these patients. It would be a mild decrease in coronary perfusion as compared to a substantial decrease on the extreme left hand side of the slide. Then as far as PE is concerned, it is 65 to 75% cases. The BP will be normal. There would be a right ventricle of the patient will not fail, and plain PE has an excellent prognosis. So look at the gradation that I'm trying to teach you, that if he says PE, then I know it's unlikely that the person will die. I will obviously treat the patient. I'll go in for anticoagulation. Even in submassive variety, I will mainly go in for anticoagulation. But if it is massive, if he specifically uses words like hemodynamic instability, central cyanosis in a patient, gross elevation of biomarkers, septal deviation which is noted on echocardiography, or 50% lung circulation getting affected, cardiogenic shock described. I mean, if these extreme features are given in a question, then I'm gonna give heparin anticoagulation plus thrombolysis, but you're not gonna do thrombolysis for the middle and the extreme right hand side data. But thrombolysis is, yes, the main life-saving intervention that you do for massive variety of PE. Whenever you will read about this topic in Harrison, he will always use this word great masquerader. Just like you can say Hrithik Roshan in Dhoom 2, who would be, three different roles he portrayed in Dhoom 2. Similarly here, I mean, what I'm trying to say, why I'm saying great masquerader is because the common presentation for all three of them is going to be shortness of breath as well as development of chest pain. And the differentials are as follows. I mean, obviously the pulmonary thromboembolism part is to be considered, but then we must take into consideration even aortic dissection. It might be written as aortic dissection, it might be written as acute aortic syndrome, and then obviously we need to rule out possibility of myocardial infarction. So what I want to teach you is that whenever a question begins with these words of shortness of breath and chest pain in an old man, even if he mentions cancer surgery, even if he mentions high risk conditions that we have discussed, pulmonary embolism is obviously one of the differential diagnoses, but there are two differentials others which must be considered. That is aortic dissection and myocardial infarction, and that is why we has mentioned triple rule out CT, because a CT can easily identify at least clot in the pulmonary artery, CTPA, and can also pick up the tear in the aorta. If we don't have a CT, we can do an MRI also, but the point is that myocardial infarction is one of the leading causes of death in India. I mean, cardiovascular mortality is very, very high, and therefore all the three diseases, because they tend to have similar or identical presentation, which is why imaging is of importance. As I've explained to you, biomarkers will be elevated in MI, that is okay, but biomarkers can also be elevated in aortic dissection. When there's a retrograde spread of the aortic tear, it can go into the coronary artery. It will cause coronary artery dissection. So again, biomarkers will be elevated. And in pulmonary embolism, I already explained, hypotension is one of the reason. Stretching of the wall of the right ventricle is another reason why you could be having elevated biomarkers. So now you're aware of, in fact, multiple reasons why, cardiac biomarkers or heart fatty acid binding protein can be elevated, which is the reason why the disease is called as great masquerader, which means that it can mimic presentation of other diseases as well. And you will have to use a clinical and laboratory judgment, and the laboratory judgment will be in the following fashion. If he begins by saying what is the first investigation to be done, I'll answer as ECG, because anybody with chest pain, I will have to do a ECG. And usually what we get in our cases of pulmonary embolism will be sinus tachycardia. All you will get is an increase in the heart rate, disproportionate tachycardia would be noticed. However, if he specifically wants to ask you about the massive variety of pulmonary embolism, where we were having that huge clot abutting the bifurcation of the pulmonary artery or going into one of the branches of the pulmonary artery, that is when the finding would be S1Q3T3. Meaning of the word S1Q3T3 would be deep S waves in lead 1. Then would be deep Q waves in lead 3. Traditionally, we read about deep Q waves in MI, but today I'm teaching you deep Q waves even for the current topic, pulmonary embolism. And then T3 would mean that there are inverted T waves again in lead 3. So let's do a quick recap. S1Q3T3 means deep S waves in lead 1. Q3, the 3 is for lead 3, deep Q waves in lead 3, and then inverted T waves in lead 3. Well, what do these findings indicate? They indicate right ventricular strain. The right ventricle is grossly distended. It's trying to work against a resistance because blood vessels are getting impacted. Blood vessels are getting obstructed. More than 50% of the lung circulation can be having a thrombus. And the learning point is the commonest ECG finding of pulmonary embolism is sinus tachycardia. But if he says massive pulmonary embolism, it is S1Q3T3. This is overall. Sinus tachycardia is also the most. If he just says what is the most common ECG finding of pulmonary embolism, then your answer would be given as what I have just currently described before you. This is in contrast to myocardial infarction. MI will always start producing ST segment elevation or maybe a T wave inversion, and it will also show a particular pattern. I repeat that again. The most common ECG finding that we encounter for pulmonary embolism would be answered as sinus tachycardia. In MI, you start getting hyperacute T waves, then you get a T wave inversion, either ST elevation, ST depression. So all those patterns I have described with respect to cardiovascular system. Now I will be focusing on the chest X-ray of this patient, and the highlight for the chest X-ray would be like if this is the right heart border and this is gonna be the left heart border. So this is like the right atria. This is superior vena cava and inferior vena cava. You know that right ventricle is niche, it doesn't form the right heart border. The current structure that I've shown is the aortic knuckle. After the aortic knuckle, what I'm showing is the pulmonary artery, then is the left atrial appendage, then is the left ventricle. And let me just complete this diagram. This I can say is the representation of the aorta. And now the blood vessel that I'm showing before you, the one that I'll sketch in color blue, is the pulmonary artery, which will be starting from the right ventricle, which is inferiorly located. And then the pulmonary artery will bifurcate into two like this. And these are the branches of the pulmonary artery that I'm showing. And now I'm showing a clot, which is causing this physical blockage. And because of this, what's going to happen is that the proximal blood vessels, the proximal vessel will get dilated. So that is why I was saying that there was a pulmonary artery hypertension and that was subsequently causing a right ventricular failure. And in these patients, the blood supply to the distal area would also be hampered. So what you can see in this diagram is a couple of findings here, which would be cutoff of the blood supply distal to wherever there's an obstruction present. And at the same time, there would be dilatation of the proximal artery segment. And the same can be seen even in a chest X-ray of this patient. So let me just represent the chest X-ray as well. They will give you a possibility. They can give you a chest X-ray or they might give you a CTP as well. But the message is that you would be able to identify a triangular wedge-shaped opacity, and this triangular wedge-shaped opacity will always be having its apex towards the heart, whereas the base will be towards the pleural surface. Obviously, the clot will not be seen. The clot I'm showing only for symbolic purposes, just to sensitize you to the fact that there would be a pulmonary infarction developing. And for this to develop, usually the size of the clot has to be small. It has to go into a distal circulation, into a distal blood vessel. Like you can see here, deliberately in this diagram, I did not show the clot getting sandwiched at the bifurcation of the pulmonary artery. Let it go forwards. Most of the time, the clot will go like this. It will go in the right pulmonary artery, and usually due to gravity will go and cause physical blockage of the right descending pulmonary artery. Clot can go anywhere. It could be more than one clot also. One goes to right, one goes to left. I can't predict it. But if it's like a small clot which is moving on, it may not get stuck at the bifurcation of the pulmonary artery or the saddle embolus like the initial image that was shown. It can go down into the distal circulation like the way I have currently represented, which is why they can give you an X-ray. And this X-ray finding that I've currently shown before you would be a repetition from your radiology class. You guys know about it. We call it Hampton hump. Then the blood vessel which is proximal to this area, let me just highlight that with a different color. The blood vessel which is proximal to this area would be dilated. So the dilation of this blood vessel can also be picked up, and this dilation of the blood vessel is taught in radiology classes as Palla sign, P-A-L-L-A, Palla. And how would you remember this? Palla sign is the dilation of the right descending because of gravity. The clot was going down, usually anatomically goes to the right side. So RDPA is right descending pulmonary artery, which is exhibiting a dilatation. And in the exam, he made permutation combinations. Like for Palla sign, no, the MCQ was what is correct for Palla sign. Options were right ascending pulmonary artery, right descending pulmonary artery, left descending pulmonary artery. So all we had to do was that we had to understand that Palla sign is RDPA, that is right descending pulmonary artery dilatation. Plus, there's going to be a Hampton hump, which is present in this case. There's a third radiological finding in this case also, which is called as Westermarck sign. For Westermarck sign, I would not like to make any radiological markings. All I can say is, what does Westermarck sign tell you? It tells you regarding focal oligemia. I mean, the blood supply to a particular segment of the lung is getting restricted. So the tests that I've currently explained to you are the initial tests which will help in confirming that I'm dealing with pulmonary embolism, because I want to rule out possibility of myocardial infarction. And then he says, what is the subsequent workup to be done, which I would like to put up as a category, that is non-imaging diagnostic testing. By non-imaging diagnostic testing, I want to do a blood test in this guy, and the blood test that would help me in diagnosis of this condition would be D-dimer assay, because every time there is a hypercoagulable state and then there's a clot that is being formed, you will always notice D-dimer assay will start showing a gross elevation. D-dimer assay should be answered as a screening test for pulmonary embolism. You see, if he will himself begin by saying patient is having pulmonary embolism, what test will you do for screening? Answer is D-dimer. But if he begins by saying old man with chest pain, breathing difficulty, then it is not pulmonary embolism right away. No, it can be MI also. So he will say, I will get ECG done. I mean, one of the basic tests that we always do for anybody having chest pain is ECG. So if he's talking symptoms, answer that as ECG. If he's going to describe the word PE, that answer is D-dimer assay. Apart from this, the cardiac biomarkers will also be done, and they can confound the diagnosis of this condition, because cardiac biomarkers in these patients can be showing an elevation as well. So 3 and 4 are non-imaging diagnostic tests which are to be done. And now I'm going to talk about some non-invasive imaging that would also be done, so that I can be confirming my diagnosis. And this was a question in the recent FMG exam. He himself mentioned that the person is having elevated D-dimer assay. He said, what is the non-invasive imaging that you would like to do in this case? And I want to prove that this chap is having deep vein thrombosis. So what I'll do is I'll be doing a venous ultrasonography. Along with that, I'll also switch on the Doppler, and you see, normally the veins, the deep veins are compressible. You can press them with the transducer of the ultrasound and they're compressible. They can be squeezed. But if there are clots present, then this would not happen. So non-compressibility, the statement to be remembered is, the Doppler will be showing, the ultrasound will be showing non-compressibility of the veins. And along with that, the Doppler will also give a signal of a reduction in the blood supply. So Doppler also produces that audible signal as well. So we are now determining that, okay, there is a problem in the leg veins which is sending clots up towards the heart. Now we will be doing the investigation of choice for this condition, that is CTPA. In earlier times, we used to do a pulmonary angiography. The gold standard is still pulmonary angiography, but see, pulmonary angiography is a invasive test. Plus, at the same time, you need a very qualified person to be able to interpret a pulmonary angiogram. So it is much more easier and convenient to do a CT pulmonary angiography, the image of which I've already shown before you. In some MCQs, he might mention about a lung scan also. The lung scan that is usually done is called as a xenon scan, and it can again pick up perfusion defects in the heart. We will be using radiotact albumin. You see, every time we are doing a radiotact test, you see radioactivity is tagged to albumin. Albumin will circulate in the blood, and the point is wherever there's an obstruction, there will be a drop in radioactivity signal. Then another test that will help us in evaluating the veins is MR venography. He is just mentioning that name. He says that MR venography can be done in case, venous ultrasound is inconclusive or is not available. Though, most of the time it is ultrasound. That is one of the early investigations that would be done, non-invasive imaging modality. And the objective of this non-imaging modality would be to determine that what is the root of evil, what is the cause of the clot going towards the heart of a person. And then the ninth test that I'll write for this chap is echocardiography. The advantage of echocardiography is that it may not confirm the dilation of the right ventricle can occur due to a lot of conditions again. So he writes this word that just because right ventricle is dilated, you can't see that there is a clot in the pulmonary artery. The clot might be, very distally located. You may not be able to see it on echo. Small clots are anyway not visible. So echocardiography does not confirm the current topic of interest, that is pulmonary embolism. Rather, it helps in ruling out other possibilities. What does it help in ruling out? It helps in ruling out crashing of a patient due to cardiac tamponade, because cardiac tamponade is again a condition of pulseless electrical activity, and even pneumothorax is described as an example of pulseless electrical activity. And then the current topic of interest, pulmonary thromboembolism, is also a possible cause. Massive pulmonary embolism is also cause of pulseless electrical activity. You can go through the section in the emergency medicine part where I've explained this, that cardiac tamponade, then tension pneumothorax, and then blockage of the pulmonary circulation, that is pulmonary thromboembolism, can contribute to PEA. So I want to rule out some common causes there, and that is why I've done an echocardiography to rule out possibility. Another condition that I can be ruling out on echocardiography is aortic dissection, though I might be requiring a transesophageal echocardiography, which is more suited to pick up aortic dissection as compared to transthoracic. At the moment, I've told you a total of 9 investigations for diagnosis of pulmonary embolism, and the 10th and the last one that I'll tell you would be an invasive test. This invasive imaging is to be remembered as a gold standard test for diagnosis of this condition. Though I've said it verbally, I'm writing at the moment, the gold standard test for diagnosis of pulmonary thromboembolism is pulmonary angiography. It may not be available always, or the person capable of interpreting it may not be available 24 hours a day in your hospital premises. That person might be at home, and the patient came late in the evening or late at night. So we would like to rely on which tests are the ones that I'm marking. We'll be relying on D-dimer assay as a screening. Along with that, we'll do a CTPA. And the third test that I'll be doing will be a venous ultrasound or a Doppler, which will prove that there was a clot that started from the deep veins, it moved towards the heart and thereby contributed to these radiological findings. And again, I would like to say that these radiological findings are again very subjective. They're dependent on the skill of the operator. I want to use technology, which is why D-dimer assay, CTPA, and venous ultrasound are one of the primary ways by which, and these reports would be given in the question. He will give you a CTPA image, and then he'll ask you, along with the clinical history, that what is the diagnosis of this case, and you'll be able to identify that it is pulmonary embolism. In contrast, if he mentions a hypertensive patient having breathing difficulty, also having chest pain, and there is a tear in the aorta, if you get the tennis ball sign, then you will say aortic arch syndrome or aortic dissection in a patient. You see, I've discussed aortic dissection in the cardiovascular part, so it would be in repetition. But the message is the common. That is why I was saying, no, this condition is a great masquerader, because it can, the central role character is the same. But then the point is, all of them are having shortness of breath, all of them are having development of chest pain. But at the same time, the reasons for why these manifestations occur would be slightly different. And that is where the role of your skill comes in. That is where the role of this workup comes in, so that we can confirm and we can save the life of our case. We will next talk about management of pulmonary thromboembolism. There are certain permutation combinations which are to be remembered. If he mentions a crashing patient or hemodynamic instability, then we are dealing with a case of massive pulmonary embolism, and I've already sensitized you to the fact that for this particular case, one of the primary approaches would be to go ahead with the thrombolysis, though anticoagulation will also be used. In the MCQ, instead of writing thrombolysis, he might be using this fancy term, that is primary therapy. So this is itself a MCQ based question. Then when do you use primary therapy in pulmonary thromboembolism? Your answer would be a hemodynamically unstable patient. What is the approach? There are two of them. Approach number one would be that I can go for anticoagulation with heparin, and along with that I can be doing thrombolysis. The drug that I can use for thrombolysis would be Elteplis. That is one approach. There is a second approach also. This approach might involve the patient to undergo surgery, or it might be catheter directed also, where we'll put in a catheter going towards the right side of the heart, and we'll catch the clot in one piece and remove it. That would be embolectomy. So the main message is, in a crashing patient, what is the approach to be used? It is anticoagulation or thrombolysis or embolectomy. If both are given, first answer would be what is mentioned here, anticoagulation plus thrombolysis. The steps to be followed for any case of massive pulmonary embolism are as follows. He says, first of all, give normal saline to this patient. That would be 500 ml. You see, you would never give fluid to somebody having left ventricular failure. But you are giving fluid to a patient of right ventricular failure, and it is not gonna create pulmonary edema because you are trying to stress the heart. You see, after all, heart is not the one which is suffering. No, it is the lungs that are suffering. So when I give fluids, it will stretch the heart, and now I will use what is called as Frank-Starling law. Frank-Starling law states that when you stretch the heart, it causes improved cardiac output. It increases the contractility. So initially we give normal saline to improve the contractility of the heart. Along with this, he says use vasopressors and inotropes. So the vasopressor that we'll be using is norepinephrine. The inotrope that I can be using is dobutamine. And with a combination of the two, I will be able to increase the blood pressure and handle cardiogenic shock of this person. The next step would be to start thrombolysis. Now the only problem is that if I'm giving Elteplis in an old man, you see, thrombolysis in a very old person can cause side effects also. They can be brain damage also. So he says that nowadays we can be using an alternative approach, which is a catheter directed thrombolysis. In catheter directed thrombolysis, the catheter, it's called as a pharmacomechanical approach, in fact. So I'll just repeat the fact again. What I'm trying to teach you is that thrombolysis in an old man can be fraught with risks because it can cause bleeding in the brain. So they decided that why can't we try and use a smaller dosage of thrombolytic drug, like instead of using Elteplis 100 milligram, use 25 milligram. But if you will use less amount of thrombolytic drug, then the problem would be clot will not be destroyed. So that problem was taken care of by what is called as a pharmacomechanical approach, that is the catheter directed. I mean, this catheter will produce vibrations that will pulverize the clot. It will destroy the clot, it will fragment the clot, and the medicine will do the rest. I said traditionally we can go in for Elteplis 100 milligram, okay, but because of the side effects, the biggest side effect of thrombolysis is bleeding. So we now have a pharmacomechanical approach, which is called as a catheter directed thrombolysis, where two things would be happening simultaneously. That is, one, the thrombolytic drug would be working, but at the same time, the vibrations produced by this catheter directed approach will pulverize the clot, it will break the clot, and the drug will do the rest, and therefore the chances of complications would be relatively lesser. Along with thrombolysis, the second drug to be used would be low molecular weight heparin. I can be using plain heparin also, but low molecular weight heparin will have advantage of a single dosage and would not require any dose adjustment. The alternative approach, which is now being also used for management of this person, is embolectomy, as I explained superiorly, which might require surgery as well. On a comparison basis, I think you would agree to the fact that thrombolysis plus enoxaparin, the main answer in the MCQ will be point number 3, that is thrombolysis plus he might not write enoxaparin, he might write anticoagulation. So this is the first agenda I would like you to remember for a case who's having a crashing of blood pressure. Now, possibility number two in the MCQ can be that he may not mention about any crashing of blood pressure. He might just say that our case is normotensive, because when I was describing before you plain PE or even submassive variety of PE, in those cases, if it's like one small chota sa clot going into the lung circulation, then it will not cause too much of problems and the BP of the person will be preserved. And if it is one single clot going in the pulmonary circulation, even the right ventricle will be normal. So if he gives you this situation that it is pulmonary embolism, the one which I was explaining is having an excellent prognosis, it is seen in about 65 to 85% cases. Here, your answer would be given as secondary prevention. I mean, whatever had to happen has already happened. You cannot do anything for that ultra small clot which is now lodged there. The body's anti-clotting system will take care of it, but you can amplify that process. You can help the body's system to destroy that clot which is present in the distal circulation by going ahead with, that is, secondary prevention with anticoagulation. You can see once again I'm saying the same thing, only that if it is massive pulmonary embolism, you go for anticoagulation plus thrombolysis, that is thrombolysis. But here, because the clot is very small, single clot, no problems, I will go in for only secondary prevention with anticoagulation. In some cases, if it is recurrent pulmonary embolism, if person is already a known case of factor V latent mutation, if a person is a known case of prothrombin gene mutation, then I can even put a IVC filter. So the learning point for you guys is, if he says what is primary therapy, that means just mark it here. If he says what is primary therapy, your answer would be, I'm going to use it in a person with crashing BP, massive pulmonary embolism. It is a combo of anticoagulation with embolectomy. You don't need to remember all these steps. Just remember, primary therapy is combination of anticoagulation plus thrombolysis. If he says what is the secondary prevention or secondary intervention that you're doing in this case, then it is plain anticoagulation or a IVC filter if there's a recurrence, and this would be done for cases of pulmonary embolism. Let us create a third possibility, and the third possibility is that the case of mine is having a normotension. That's okay. I mean, you see, luckily the BP of the patient is perfectly preserved, but there is a development of right ventricular failure. In those cases, he says that you have to individualize the therapy. Let me just repeat my statements now, because 3 points have come up. This that I've written before you is for the submassive variety. The first data I gave you, massive pulmonary embolism. The next data I was given you was first one single clot or maybe two clots going in small circulation. Some segments are affected. Now I'm telling you submassive pulmonary embolism, which is normotensive with right ventricular failure. Here he says that if there is in the setting of a clinical deterioration, like our case is still at the moment having low oxygen saturation, his oxygen saturation is low, his ABG report is showing severe respiratory alkalosis, there is an increase in the dead space, the alveolar arterial gradient is increased. I mean, per se, the person is not showing, the person is showing a progressive deterioration. BP has not crashed at the moment, but can crash now. The BP has not crashed at the moment, but can crash. So he says that even in this case, it is dependent on the I would say the decision of the doctor. But if there is a right ventricular failure, if there is a right ventricular hypokinesia that is documented, in fact, let me just speak about this hypokinesia component also. In the earlier part of our discussion, I have spoken regarding this word, that is McConnell sign. I would like to touch upon this once again. McConnell sign basically means two things. It is right ventricular hypokinesia. Understandable, right ventricle is dilated, so it's not working properly. But there is a second finding which is also seen here, which is in the apex of the right ventricle. That is right ventricular hyperkinesia. So McConnell sign is a combination of, remember my statements, McConnell sign is a combination of right ventricular hypokinesia and right ventricular apex hyperkinesia. So if he's also mentioning in a question with respect to these aspects that I've said, and in the setting of a clinical deterioration, he says then again, the decision that has been determined on the basis of clinical studies would be to again thrombolyze this case. So now you know that thrombolysis would be done in which settings. Thrombolysis will be done for a crashing patient and also for a patient who can crash in future. If he says yourself normotensive patient, he will deliberately write this normotensive word. So you will be thinking, okay, if it is normotensive, nothing to be done. But simultaneously he will mention that the right ventricle is like there is multiple chota clots present. This that I've currently shown before you is like large number of multiple clots present. So there is a pulmonary artery hypertension, there is a right ventricular failure developing. So okay, I will decide to thrombolize. It is individualized the therapy. In fact, it's not individual therapy. I'll just clarify that. It he technically means, I mean, it depends on the decision of the doctor, but the clinical trials have shown that you should always go for the aggressive approach. I mean, the meaning of the word individualized therapy is not that you have to go for aggressive or I would say a moderate conservative approach. He says that by individualization, he means that check out the clinical profile. If there is no improvement in the oxygen saturation, rather his heart failure is going to cause the JVP to become substantially more elevated. There would also be a hepatomegaly developing in this guy. So he says that if you see that the chap is deteriorating, it is better to thrombolize in this case. Plus, obviously, anticoagulation. Anticoagulation is universally done. The only thing is, when do you thrombolize? Either in a crashing scenario or in a case where there is going to be a normotensive with McConnell sign with right ventricular failure, or he says right ventricular hypokinesia. So that is the approaches that I would like you to remember. In the older edition, he was focusing on only two things. He was only talking about massive pulmonary embolism, or he was talking about plain pulmonary embolism. He's incorporated a parameter in between of the two as well, where he says individualized therapy. And this he has said that in setting of clinical deterioration, well, we have to then be a little more aggressive, and we will have to go in. Anticoagulation will anyway be done, but thrombolysis will also be added. So towards the end of this video, a quick recap with respect to massive pulmonary embolism and plain pulmonary embolism. Always in a question, check out the blood pressure values, which would be crashing on the left hand side but would be normal with respect to PE. Then if you look at the echocardiography findings, massive pulmonary embolism will be having a right ventricular hypokinesia of the free wall, and at the same time there would be hyperkinesia of the apex. That hyperkinesia of the apex is what I'm not writing at the moment, but the right ventricular function will be described to be normal with respect to pulmonary embolism. Now on the left hand side for massive pulmonary embolism, if I'm gonna do an ECG and I'm answering S1 Q3 T3, it definitely makes sense. But for the right hand side, if I do ECG, then I'm not supposed to answer it as S1 Q3 T3. For that chota clot or small perfusion defect, the ECG finding would be a sinus tachycardia. In both the cases, that is both massive and the plain variety of pulmonary embolism, he might mention post-operative patient, he might mention cancer surgery, orthopedic surgery, joint replacement surgery, any kind of major surgery. And then post-operatively, mostly day 2 or day 3, there would be a development of sudden onset respiratory distress. Along with that, chest pain description may or may not be given, with findings that I've already explained to you with respect to loud S1 and widespread second heart sound. In both the left side as well as the right hand side, if I'm gonna check out the D-dimer assay report, the D-dimer assay will be elevated in both of them. However, in massive pulmonary embolism, if he will give me a CTPA image, the CTPA image might be able to pick up a clot. The clot could be present in one of the pulmonary arteries, or the clot could be present at the bifurcation of the pulmonary artery, that is a saddle embolus. It could be like sitting between the bifurcation, and then the clot can propagate. Like this clot can propagate, and it can subsequently contribute to even 50% of the lung circulation. But the pulmonary artery circulation will be normal, because in plain PE, it's the distal blood vessels that would be getting affected. Now comes the core issue. He will say, what will you do if it is a case of massive pulmonary embolism? And that I've already explained to you, that I will be anyway using anticoagulation for both the left side as well as the right hand side. And what is the difference between the two is that thrombolysis will be done. That thrombolysis approach I also told you, we can go ahead with thrombolysis 100 milligram, but the point is we can go in for a catheter directed approach also, where the dosage of thrombolytic drug used will be relatively lesser. So most of the time these MCQs will end with this difference that I've explained. There are 3 different slides where I've said the same thing. I mean, you'd be wondering, why am I emphasizing the same thing again? Because I see people making mistakes. In the previous slide, I was dividing it into 3 parts, the massive, the submassive, and then the plain pulmonary embolism as is described in the textbook. But this slide is important for you to be able to crack the questions. That is, in a hemodynamically unstable patient, thrombolysis is one of the primary approaches which is to be used. Now you're aware of 3 indications for doing thrombolysis. That's gonna be acute ischemic stroke with the window period is 4.5 hours. We can be doing thrombolysis even in MI, ST elevation MI. The door to needle time is 30 minutes, and thrombolysis in massive pulmonary embolism can be done up to 14 days of the event. I repeat the statement. In acute ischemic stroke, it is 4.5 hours, explained in neurology. In ST elevation MI, the door to needle time is 30 minutes. And here I'm teaching you that thrombolysis can be done up to 14 days of the actual event. Up to 14 days of the actual event. I mean, the clot could have 14 days of the event. I mean, the clot could have landed in the pulmonary circulation today, but he says that the window of opportunity here is huge, and intervention will help in saving the life of these patients. If you have worked in COVID wards, you would have seen pulmonary embolism occurring quite frequently. COVID itself is a hypercoagulable state. If not, still, I've given you those case-based scenarios which are usually asked in the exam and are important to solve MCQs of this topic. Thank you so much for your patience and hearing me out. It did take a while to finish this, but as I said right in the beginning, this is going to be the second most important topic in pulmonology after pneumothorax, and that is why I have tried to give it an intensive discussion. Thank you so much.